Okay, so I am Terry Watnick. I am an adult nephrologist at the University of Maryland. I have been involved in caring for PKD patients and also in various aspects of PKD research for actually all of my career. So with that, I just want to really welcome everyone who's here in person and everyone who is online. We really appreciate your participation. And I also want to thank all of the speakers for helping educate us and teaching us about PKD. So our first topic is PKD nutrition, and we're going to have two speakers, Dr. Fouad Chabib. He's a nephrologist at Mayo Clinic. He has expertise in the management of PKD and its complications, and he's actively involved in clinical trials and the translation of novel treatments for ADPKD in clinical practice. And he will be joined by Dr. Han, who's a kidney nutrition specialist who works in the Department of Nephrology at Atrius Health at Tufts Medical Center in Boston, and she's a member of the advisory board at the PKD Foundation. So with that, I'm going to turn it over to Dr. Chabib.
Thank you so much, Dr. Watnick. Thank you for the invitation. Can you hear me and see me okay? Can you guys hear us or hear me and see the screen?
Yes.
Okay, perfect. All right, well, thank you again. So the first session is going to be on PKD and nutrition, which is, I believe, a very important topic, especially that it's something that our patients have control over, and it's important to understand where we're at with what we know and what is safe. And I'm glad Dr. Han is going to be joining me as well to give you some additional tips on that from a nutritionist standpoint with a lot of her expertise as well. So over the next 10 minutes, I'll go over some data, what's known in animal models as well as in patients, and what we think is good recommendation at the moment, which might be changing in the future, and then have Dr. Han, and we'll move that to Dr. Han, and then we'll have some questions as well, or time for question. So as Dr. Watnick, I'm very passionate about PKD. That's all I do day in, day out, from clinic to research. And I'm very passionate about finding the next best treatment, hopefully to slow the disease process. So PKD is a really complex interaction. So either you probably have a family member, most commonly you would have a family member with PKD, so you have inherited the same exact mutation or pathogenic variant as your other family member. But there's a lot of things that you might not have control over, like epigenetic, which is changes in the cells that are beyond the genes. And then there's things that you can control or modify, which are how much fluids you're eating, you're drinking, how much salt you're eating, if you have excess weight, and so forth. So there's a lot of things that you have control over, and those are things that it's kind of probably sustained and cumulative, in a sense that if you start early taking care of your health, it's going to pay off later on to slow the disease process, which is quite complex. But there's now well-known metabolic dysfunction or changes in how the cells are using the energy in PKD. And then, of course, you will see the clinical outcomes, which is your blood pressure, cyst bleeding, infection, how big your kidneys are. So definitely we'll focus on this today, and you'll hear a lot of other things today in the session, other sessions, but our focus will be here. I won't go into the complex pathways. It's just to tell you how complex things could be in PKD, in terms of many things could go wrong once you have that change in the DNA code. We think right now that the mitochondria has quite a bit big of a role in terms of how it's looking like and how it's functioning in PKD, and diet can modify that as well. So you might be able to really help your PKD through this. Now, to make it a little bit simple, so again, you have a new mutation, or most likely you have inherited this one of those mutations. Then we think that there's higher molecule called cyclic AMP inside the cell that leads to higher cyst formation. So if you drink more fluids and less salt, you'll be able to suppress that thirst hormone or water hormone called vasopressin, or AVP, and that should help a lot your polycystic kidneys. On the other hand, focusing on the metabolic reprogramming, or the mitochondria and the PKD, the cells have a little bit of trouble using efficiently the the energy or glucose. So definitely there's a shift towards lactate, which is less efficient for the cell. So there's less acetyl coenzyme A, for example, CoA, and having these different dietary interventions can help mitigate that. So for example, here we'll talk in details about caloric restriction, intermittent fasting, time-restricted eating, ketogenic diet, and beta-hydroxybutyrate, or what's known as ketocitra, or one of the things in ketocitra. So a lot of these things could help theoretically reshifting this into a more efficient energy consumption and then reducing cystogenesis or the cyst formation. So in terms of dietary interventions, so caloric restriction is you just kind of cut down the portion. So you eat less by 10, 20%. So instead of adding a second portion or anytime you're putting things on the plate, try to think, okay, can I do a little bit less today? Intermittent fasting is where you go 1 to 3 days a week where you don't eat anything except you just hydrate yourself. So you reduce on that day 80% your calories. So you almost don't eat anything on that day, but you hydrate yourself. Time-restricted eating is a little bit more common. That's what most people would refer to it as intermittent fasting, but in fact, it's time-restricted eating. It's where you have only one window, smaller window where you eat, let's say you skip breakfast, you eat lunch and dinner within 8 hours, and then the rest you just hydrate. That's called time-restricting eating, and that has helped reducing weights as well. Ketogenic is a little bit more advanced, where you have very low carbohydrates, so less sugars, less pastas, pizzas, desserts, and then more fat, maybe the good fat, and then moderate protein. And there's different types of ketogenic diet, plant-based versus animal-based, and I think there's a big difference between both of these, and there's a lot to be learned later on, or as we learn more, especially in PKD. They do have some risks, so the key is to lose weight, basically. That's the key message here today, whether you do it with any of these interventions. We think caloric restriction is the more feasible one that has less risks and has a lot of data backing that, but it does have some risks, especially in younger patients, to have some bone loss and anemia. Of course, we don't want people to get, or patients to get malnourished. So if someone is body mass index is close to normal, and that's Dr. Han will show that. But if someone is close to normal, we don't want them to get malnourished, but we want them to maintain a normal, healthy weight. Intermittent fasting also could lead to some dizziness, weakness, low blood sugars, irritability if you're not eating. Then time-restricted eating also, you need to make sure that you're well hydrated, you're not getting malnourished. And ketogenic diet has its own potential risks. It's been known for a long time, especially for seizures in kids. In fact, Mayo Clinic was the first to describe that in kids. And then, so it's important to know the long-term risk factors. We think there's going to be higher cholesterol, higher uric acid, kidney stones, question mark of long-term sustainability as well. So why there's all this hype about these dietary interventions? Because there's a lot of data in the lab. So basically what we call animal models or preclinical models is we modulate all these interventions on PKD animals, so mice or rats who have PKD. There's a lot of studies starting also from Mayo Rochester, Dr. Cheney, showing that even just 10 to 20% reduction in calories can help your kidneys to grow much less, or the animal PKD kidneys to grow much less. There's also other big groups as well that showed that later on. The intermittent fasting in one of the models didn't show any benefit. However, time-restricted feeding did show that, as well as ketogenic diet, showing that there's less PKD with these interventions. There's also how much you hydrate. There's also some good data that if you hydrate more, it's better. Now, this is in animals. One of the models didn't show benefit, and then I'll show in humans that's a little bit more complex. The beta-hydroxybutyrate is something you would probably see when you go to grocery shopping or health places. It's a medical food in a sense, and when you see like keto-friendly or keto things, that probably has beta-hydroxybutyrate. It's a type of a ketone body, so you're trying to instead of yourself have some starvation, you kind of give that ketone, that starvation molecule to the body. It's typically produced in the liver during periods of low glucose, so during fasting or low carbohydrate diet. There's a study from California showing that beta-hydroxybutyrate could help PKD animals. But the data in humans, it's still lacking, and there's groups who are working towards that right now. Now, for sure, we know it's been proven over and over again that the excess weight or having obesity or overweight causes faster PKD. So the kidneys grow faster when you have excess weight. So it's very, very important that you take into account that early on. So if you have a family and they're at risk of PKD, so you don't know if they have PKD or not, it's important to establish a healthy lifestyle inside your household, meaning that encourage them to hydrate a lot, but also don't gain the weight, which can be difficult and challenging. But if they start early on being very active and know what they eat and don't gain weight, I think it's going to be very, very helpful for your kids, in addition to you as well. But the earlier you start, the better. Now, weight loss also has shown in one of the studies from Colorado that whichever strategy you use, so whether you use daily caloric restriction or intermittent fasting, if you lose more than 5% of your weight in this study, there's less growth of your kidneys, here seen in annual change of kidney volume per year. Now, how about clinical trials on ketogenic diet? There's a nice work from Germany looking at, they start with a pilot showing that the short-term ketogenic diet can induce that ketosis that we talked about. The short-term dietary intervention is feasible based on this smaller study. Then they did a little bit of a bigger study, and they had groups that have only intermittent fasting or water fasting, then a control group just eating as normal and ketogenic diet. There's some side effects that we mentioned, most of them. There's the keto flu that comes with the ketogenic diet. They also showed again that short-term is feasible in PKD, and you could lose weight with that intervention. Now, this is, bear in mind, it's still a smaller study, so we still need bigger studies to make final determinations, but it does definitely have a merit and a possible benefit. So more to come, hopefully, in the future. How about water? So we always kind of drill in your, probably each time you see us, drink a lot of fluids, drink that 3 liters, that 100 ounces. Make sure that your urine is always dilute, it's not yellow, right? So unfortunately, so there's still a lot of merit, and I still recommend that for all of my patients. However, there's a study in Australia that looked at about 184 patients who were given coaching to reach a high level of water intake through dietary interventions, through calling, through different type of things, what we call water prescription. And they compared that to someone who just kind of goes on with their life and they drink and eat normal. They followed them for 3 years, and they didn't see any effect between the groups in terms of how the kidneys grow or if the kidney function slows down. But also the importance is in the details that only half the patients in this group were able to reach that dilute urine, which means it's quite challenging to really reach that just on your own. But still, I think anything can help that you can suppress that vasopressin. It's going to be very, very helpful. So drinking more fluids, but also eating less salt. So there's something called osmolar intake, which means how much salt and protein we take. The kidney has to get rid of those in the form of urine. So if you eat a lot of salt, you're going to need a lot of urine to kind of produce that, but also you're going to need more fluids and more water intake to suppress the thirst hormone. So if you eat less salt, you're going to be needing less fluids to suppress that thirst hormone or water hormone, vasopressin. Definitely, there's a lot of studies out there. This is one of them that showed the more salt you eat, the faster your kidneys are gonna accelerate, reach kidney failure, and reach dialysis or transplantation. So definitely, it pays off if you eat less salty, and definitely work with your dietitian to understand where's the salt in your food and how hidden it is. So finally, in the last minute here, and I'll move it over to Dr. Han, as in those are what we call the PKD diet at the moment. So again, this might change in the future, but the take-home message is only few. So make sure that you try to work your best to lose the weight. It's difficult, or challenging, but it's important to maintain a healthy weight. Probably maintaining a low calories is the easiest way. Also, there's a lot of practical tips maybe Dr. Han can share, how you go to the grocery shop and you just kind of shop in the perimeter where it's all healthy and not processed food. That might be helpful. Calorie restriction and portion control. Eating out less, maybe. Also, aim for a hypotonic urine or a dilute urine. So probably drinking 3 liters or more, depending on your situation. If you exercise a lot, if you work outdoors, you might need more. So I tell our patients to gauge with the color of the urine. We can be a little bit more complex and do a water prescription, but for the most part, if you gauge with your urine, you'll be able to push yourself and say, okay, maybe I'm getting dehydrated now. And then protein, we don't restrict unless your kidney function is a little bit lower, as well as making sure that you're healthy overall. So no smoking, encourage your kids not to smoke, vegetables, of course, minimizing concentrated sweets, maybe 2 cups of coffee or less, less than 2 cups of coffee. And then making sure that you, if you get closer to a vegetarian plant-based, not necessarily like restricted plant-based, but closer, most of the days you're less meat, less red meat, I think it's going to be also very helpful in your CKD as well as PKD. And with that, I'm going to stop sharing, and I'll move it over to Dr. Han. I'll have her share her screen since she has newer slides. Thank you.
So nutritional goal for the PKD, the number one goal is maintaining healthy weight. So I'm going to discuss about the maintaining healthy weight, adequate fluid intake, and eating healthy. There will be a little bit of dietary restriction, and there are a variety of different diet. And Dr. Shabib already explained about all the data for the dietary different types of diet. And also we are looking at control existing medical conditions, diabetes, high blood pressure, and other conditions which is not going to be covered today. So we always talk about the weight using body mass index. So when we look at the body mass index, it's calculated by weight and height, and BMI of 15.5 to 24.9, we call this as a normal weight range. Now, I have to show this like a cartoon, because the reason is we have exactly the same height, 2 men. One is very muscular, the other one is pretty a fat person. So, but they do have exactly same BMI. So that's why we have to think about other body composition to different like muscle mass and fat mass to make sure that you are still maintaining good healthy weight. And those are always with adequate calorie intake and exercise. So this is a BMI chart, and this is just have a different height and also different weight. And we are looking at this green range as our goal of the BMI. Okay, so how to maintain healthy weight? So first of all, if your weight is in good range, you just maintain your weight. But if someone is overweight or obese, we usually reduce calories between 500 to 1,000 calories per less per day. And it's just, it will just make 1 to 2 pounds of weight loss per week. So if someone wants to follow less than 1,200 calories per day without their body size, usually these are not desirable because there will be a lot of nutrient insufficiency. So we recommend just a decent weight loss I'm talking about in general, not specific medical intervention. So with this low-calorie diet, also, we need to give a moderate amount of protein, and the goal is 0.8 gram per kilogram, because that is the goal for the PKD. And it can be a little bit more, but those will be, I usually individualize based on the amount of their the fruit and vegetable consumption. And we do not recommend just a lot of carbohydrate, but if someone needs carbohydrate, it should be complex carbohydrate and more fruit and vegetables as part of the carbohydrate. And everyone should do some physical activities. And we do not recommend strenuous activity because of some rupture for the cyst for a certain patient. Recommend the high fluid consumption and different types of diet. It should be fit for patient's lifestyle. So the second goal is to make sure patient drinks enough water, enough fluid. So in general, we recommend more than 3 liters, more than 96 fluid ounces per day. And we do not recommend no sugar-containing fluid like juices or soda. We do recommend just 1 cup of coffee, and actually it's 1 to 2 cups, and depending on the size of the cup, so we usually go by 1 cup. And many of our patients, they don't even drink coffee, so that's usually fine. But we also monitor blood sodium level, because sometimes when you drink too much of water, the blood sodium goes down. So depending on the patient's blood sodium level, we can adjust for the fluid intake. And patient take tolvaptan, we usually recommend a higher fluid recommendation. So the next thing that we try to teach our patient is the eating healthy for PKD. I have to combine with the recommendation for PKD and CKD, chronic kidney disease. The reason is PKD is one of the causes of the CKD. So the earlier stages of the CKD, with the normal function of the kidney function with the PKD, the restriction should be a little bit different. But once they reach for stage 3 CKD, their recommendation is very, very similar. So the patient has to follow appropriate diet to slow progression of the CKD. So the protein for only PKD patient, I still go by 0.8 gram per kilogram, but also sodium recommendation is between 2,000 and 2,300 milligram per day. And 2,300 milligram of sodium is 1 teaspoon, measuring teaspoon of salt throughout the day. It's very little. The potassium and phosphorus and oxalate, all of these are going to be individualized, and especially potassium and phosphorus, we are looking at blood level. We do not restrict potassium and phosphorus without looking at the blood level of these two, the electrolyte. So, and then we also look at type of diet. If someone wants to follow vegetarian diet, regular diet, it's all based on patient's preference. So most important fact is diet should be individualized. There is no one diet to fit everyone. So we already talked a little bit about the weight management and little calories. So this, the second important thing is that we are looking at the nutrition and especially protein. The protein should not be used as main energy source, because protein increases filtration rate in the kidney, and also the protein has to go through the kidney to produce energy. And this will affect the progression of the kidney disease. And amount of protein recommendation is based on body weight. So we don't do like 50 gram protein for everybody. We have a 100 kilogram patient, 220 pound, usually go higher protein consumption than a 100 pound person. So all of these are adjusted. And then we have to provide adequate calories to maintain body weight or lower calorie for weight loss. So with losing weight, also protein recommendation varies because it's based on the body weight. The high protein, low carb diet for weight loss is the most popular diet. I think nowadays people also take Ozempic, so they lose weight fast. But this type of diet, high protein, low carbohydrate diet, is not recommended for a PKD patient and also CKD patient because these promote cyst growth with a high osmolality. Also, it enhances the progression of the kidney disease. The plant-based diet is not better than regular diet. It's actually there were no sufficient data from the Kidney Disease Outcomes Quality Initiative in 2020. However, since 2020, we have more data, and then now the trend is people eat more, follow more vegetarian diet for the healthy eating. So this is an example of a moderate protein diet. You can see there are small quantity of the protein, like 3 to 4 ounces, and then have vegetables, fruit, and complex carbohydrate, and provide healthy eating. And also there are some vegetarian diet, very similar kind of composition. The other important fact is the sodium. Because sodium is very important for blood pressure, also possible effects on cyst growth. So the goal for the sodium per day is between 2,000 and 2,300, and it's exactly same as 5 grams of salt. And there are different types of salt, and many of our patients ask me about what type of salt is better. But the answer is regular iodized salt, kosher salt, sea salt, Himalayan salt, all of them provide exactly same amount of sodium per 1 teaspoon. And the other thing that everyone should do is check a nutrition fact label when goes to grocery shopping. Anything fresh, they are all low sodium. And then people also use the different spices or salt substitute. So for an example, Mrs. Dash or fresh herbs, they are all good substitute. However, light or no salt substitute, they are usually very high in potassium. So you have to be very careful to use one of those salt substitute. So those need to be, you can check it through the nutrition label. So I just give an example about reading nutrition label. Always check the number, the serving size, portion size, or number of servings per container. And then here I used this label because there is a mistake, because sodium should be used as a milligram and this is gram. So if you just look at the most of labels, I'm sure that now everything is fixed, but these are more like milligram, and I usually recommend about less than 200 milligram per portion. That would be better. So you can have like a total day of between 2,000 and 2,300 milligram of sodium per day. So those two, protein and the sodium, those are very, very important for all of our patients. And also the next topic, and a lot of our patients also follow low potassium diet. However, why it's not just the diet, elevate the potassium. And potassium is very, very important for muscle contraction, especially for heart. And the patient takes a different type of blood pressure medications, such as lisinopril, losartan, and also water-based spironolactone. And then also the patient is dehydrated or very high blood sugar. Usually can cause elevation of potassium. So we need to find out the causes of elevation of potassium in the blood. And then also patients should know about where what level patient has. Because I just put the safe zone as 3.5 to 5, but it varies slightly in different institutes. And first, know your potassium level. And if someone has this high potassium food, but the potassium level remains normal, there is no reason to follow low potassium diet. So all this potassium should be individualized. It's similar to phosphorus, because the phosphorus is very important, and a lot of patients still follow low phosphorus diet. In CKD, most of this patient have high phosphorus. It's like advanced stage of the CKD. So more like stage 4, GFR is less than 20, and then the phosphorus start building up. And all the processed food, they use phosphate-based food additives. And also it contribute to very high osmolar diet. So that's why we do not recommend all of our patients consume more processed food and anything. So that's one of the reasons that we make sure everyone should eat healthier and fresh food. And phosphorus has something called different variability. So the phosphorus from the cheese is the different absorption rate than from nuts. So all of these are going to be discussed with the kidney dietitian when you just meet with them. The last nutrient that they also talk about is oxalate. However, the oxalate, we do not have any recommendation of cutting down oxalate food for ADPKD patient unless the patient has calcium oxalate kidney stones, because most of these high oxalate food are also healthy food. And although the PKD patient have a little higher risk of the kidney stone, we do not recommend it for all of our patients. And Dr. we've already discussed all type of diet already. So I just summarize in one page. So a low protein or a moderate amount of protein with a low sodium diet, that's our more like very typical regular PKD diet recommendation. And if a patient wants to be a vegetarian, there are different types of vegetarians or vegan. All of them are more like a patient's choice. Ketogenic diet is there are some adverse effects at the beginning. Also, it probably lasts longer, or there is some problem with compliance with this diet. But these are usually designed for weight loss. And also plant-based keto diet with beta hydroxybutyrate. We are waiting for more data so we can recommend this diet if it's really good for the PKD patient. We also recommend Mediterranean diet because it's also heart healthy for CKD patient. Intermittent fasting is also patient's choice because all the nutrients can be provided the good way, but we just concern patient who has diabetes and then sometimes take insulin. We don't always recommend intermittent fasting for those patients. So in summary, for PKD patient, healthy eating should include about keeping the maintenance of a healthy weight, moderate to low protein, and make sure that it's going to be to meet with the weight goal, but it's not going to be high protein, low sodium, high fluid intake. And also, there is no sufficient evidence for the vegetarian diet or intermittent fasting. It's better than regular diet for PKD patient so far. But again, we are just waiting for more data and more review. And also, there is no beneficial effects on cyst growth in short-term study. And Dr. Shabib already explained it earlier. So we are still waiting for the data. There are more studies for keto diet. They're on the way. So you just watch for the new studies. And all diet recommendation for PKD patient should be individualized based on patient's current medical conditions, also weight status and cultural background. Thank you.
Okay, thank you to the speakers. Those were great talks. We're running a little behind time, so we're going to take only 2 questions, one online and one from the audience here, if there are any. So we'll start. Any online questions, Rachel? Okay. Any questions from the audience here? Okay. I guess none. So we're going to move on then. Okay, so our second topic is, whoops, sorry.
No, just saying thank you. Take care.
Oh,
Thank you.
Thanks. Bye.
okay. Thank you, Fuad.
Thank you.
Thank you, Dr. Han. There is a question? Okay. Oh, okay. Dr. Han, what would you say about decaffeinated green tea?
That is fine.
Okay.
Moderation.
Yeah, I would just say make sure there's no oxalate in there, I guess, if you're going to drink a lot of it.
Yes.
Look at the label.
I don't recommend if you drink about 2 liters of the green tea, which
Yes.
is it's too much. But green tea also has a little bit of caffeine. So as long as you just have about, I think about 250 milligram of caffeine, I believe that is the goal. So if you just drink a little bit, that will be fine.
Okay.
All right. Thank you.
I do see an online question, so I just wanted to make sure that was answered. I can bring it up too if you don't see that.
When do
Okay,
you
yeah.
assign a dietitian to your patients? Is that the one?
Yeah.
Yes.
Yeah.
Yeah, great question. Yeah, I would say I think the earlier the better. I always offer it early on. I don't think you need to wait until our patients have chronic kidney disease, especially with all the complexities of all the different things, and at least kind of go over the sodium portion because everything is hidden, and it's kind of have some meal plans and so forth. And if there's excess weight, I definitely like to send them to our. But I don't think there's a real guidance. I think it's preference. If you have access to a dietitian, I would say I offer it to all my patients, and most of them they like to see a dietitian or nutritionist. Yes.
Okay, one last question, and then we're going to move on.
Sounds good.
From
You
Matt.
guys hear me?
Yes.
Hello?
Yes, we can.
My name is Matt Manolfi. I'm a kidney donor, living donor transplant, and I've been cooking for my wife for many years, inhibiting salt intake. Now, I've growing up and reading a lot about MSG, monosodium glutamate, has been one of the worst things you could possibly ingest, but I've never found a study to the effect that it's detrimental to any health. And as a salt substitute and a flavor enhancer, I try to incorporate it in a lot of recipes. I'm wondering what do you think about it? Have you found anything as far as its detriment to health? Is it bad? Can it be a good substitute for salt, which we strongly restrict in our diets?
I can answer that question.
Yeah.
So first of all, the Americans usually consume between 4,000 to 6,000 milligrams of sodium every day. It's not adding salt on the table. So what happened is we do recommend, I think that you are doing a great job to checking the MSG. We did not find any study, and that's actually like a part of them. And especially when you go to the restaurant, you just ask any Asian restaurant, they all use MSG. So these restaurants, you have to make sure they are not using the MSG, but they often use it twice in the sauce when they make, and also they put another MSG for just right before serving. So you have to make sure less sauce and no MSG before serving. They also, the other thing is when you go to grocery store, it said accent, that's also MSG. So any meat tenderizer, anything enhanced flavor, they all have sodium. The type of the salt substitute, you have to look at the sodium content. And as I told you, like if it's like less than 200 milligram of sodium, you may be able to use it, but the portion is usually 1/4 teaspoon or 1/6 or 1/8 of the teaspoon. So it's a very, very little. If you could make use the more on the fresh herbs, anything fresh or some powder like garlic powder, onion powder, any of those, they are all low sodium. They are all fine. Also, we recommend the Mrs. Dash, but I heard that it's not that great. And also use the lemon and any of any spices you can choose. But the using salt substitute, you have to be very careful about the potassium, because many of our patients, they do not have high potassium. By cutting down sodium using salt substitute, usually there is a risk for elevation of potassium. So what you have to do is understand about the potassium. And if someone has a very, there is no there is no one answer. You have to check your sodium and then just to try to reach about between 2000 and 2300. But always remember, you can have any fresh food without any limit. I hope this answers your question.
Okay, so we're going to move on now to our next session, which is genetics and genetic testing. Our speakers are Dr. Neera Dole, who is a Senior Associate Consultant and Director of the Mayo PKD Center of Excellence, and Kayla Colbert, who's a board-certified genetic counselor in Mayo Clinic Center for Individualized Medicine. Kayla, nice to see you again. We worked together on a genetics presentation. So I'm going to turn it over to Neera.
Right, sounds good. We are doing this as a team in that Kayla and I are sharing the same slide deck. And so Kayla, when you are ready, we can advance the slides.
Sounds good.
Okay, so I thought I would start our discussion of testing, genetic testing, by presenting someone with PKD. So this is a 29-year-old woman who has a family history of PKD. Her mom was diagnosed when she was in her mid-20s, and now the mom is in her mid-50s, and she has stage 4 or advanced kidney disease. And the 29-year-old, my patient, was recently diagnosed with PKD when she had a screening ultrasound that showed multiple cysts bilaterally. So someone with a family history with a finding of cysts, that makes the diagnosis of PKD. And at the time she had the ultrasound, the kidneys were not terribly large. The right kidney was about 10.5 centimeters, which is normal in length, and the left was 12.2 centimeters. She had a blood pressure that we would say is high normal for a healthy young 29-year-old woman. Her kidney function is normal. Her urine analysis is normal. Next slide, please. And she gets imaging. She gets a kind of imaging we call volumetric MRI. And what you're looking at here is these are the kidneys. So you're looking at a what we call a coronal view, where the kidneys are in cross section here. And each of these bright white dots in the kidney is a kidney cyst. Thank you. And so and then this up here is the liver that we're looking at. So you can see she does have a lot of cysts in each kidney, but when we look at this image, what I would say is the kidneys still look fairly normal, because a lot of that normal black tissue is normal healthy kidney tissue. And so by measuring her kidney width, length, depth, we're able to calculate kidney volume for both the right and the left kidney. And we know how tall she is. So we calculate what we call a height adjusted total kidney volume. And then if we adjust that further for her age, we get what's called the Mayo imaging classification. And she is Mayo imaging classification 1C. Next slide, please. And what that means is here. So on the y-axis, going from top to bottom, is total kidney volume, height adjusted total kidney volume. And on the x-axis, going across, is the age of the patient. And what you can see is those people who are in the highest imaging class, so 1E is the highest risk imaging class, tend to have the largest kidneys at any time, at any age, whereas those people who are the lowest risk, the 1A patients, tend to have the smallest kidneys at any age. And we know that in PKD, the risk of loss of kidney function it is reflective of the kidney size. So the bigger the kidneys, the higher the imaging class, the more likely there is to be early onset loss of kidney function. And so we know, for example, when we look at this, the 1D, 1E patients are considered high risk, and most of the 1C patients are considered high risk as well. Whereas the 1B patients are usually patients who, if they develop kidney failure, it's much later in life. And the 1A patients almost never develop kidney failure. Next slide, please. So it turns out there are two risk prediction tools in PKD. One is based on Mayo imaging classification, which is the total kidney size adjusted for the patient's height and adjusted for the patient's age. The other is something called the Pro-PKD score, which is based on the genotype, so based on the gene causing the PKD and some clinical features. Next slide, please. And these tools just allow us to determine who's likely to lose kidney function at a very early age versus who's likely to have good kidney function later in their lives. Next slide, please.
Yes, so I think here is where I will take over for a little bit and just give you guys a background on genetic testing. In order to go into that, I think we really need to take a step even further back and answer what is DNA and what are genes. You can think of DNA as the body's instruction manual or blueprint. There are chapters in this manual which we call genes. To oversimplify just a bit, you can think of a single gene as coding for a single protein. These proteins have different jobs in the body. We have genes that make proteins that specifically work in the kidneys to help develop the kidneys and to help them function correctly. Genetic testing then refers to using a laboratory technology to essentially read specific genes that we're interested in and look for any spelling errors or variants. You may also hear the word mutations in the DNA that might lead to a dysfunctional protein being produced, which can then lead to a specific disease. In this image here, you can see that a variation in this gene is leading to a protein that's not shaped normally, so it can't do its job correctly. A mutation or a variant can also lead to a completely absent protein product that won't do the job it needs to do at all because it doesn't exist. So when is genetic testing used? Well, right now, most genetic testing available is for monogenic conditions, where just one gene is the main or the only driver of that disease. PKD is one of those monogenic conditions, and there are many different genes that can cause PKD, even though I think the two most common that you may have heard of are the genes called PKD1 and PKD2. There are other conditions where there may be multiple small genetic risk factors that are additive and can lead to a higher risk for a condition to happen. Those things may be further influenced by environmental and lifestyle factors. We consider those to be polygenic and multifactorial. Polygenic meaning there's many genes involved. We're still working on creating genetic testing to better assess those types of conditions, but PKD really falls into that monogenic space where we do have genetic testing. So why consider genetic testing for PKD? Knowing the exact gene that is the cause of someone's PKD and the exact variant or spelling error within that gene can do a few things. And Dr. Dahl had touched on this already, that this can help guide prediction of disease progression using that pro-PKD score. If it's a truncating variant, so it makes that gene even shorter, that protein shorter than it's supposed to be or not exist at all, that can tell us something different, as opposed to whether it's a missense variant that kind of misshapes the protein a little bit. We also share our genes with our relatives, so finding the cause of PKD in you can allow for other relatives to get targeted testing, which may lead to earlier interventions for those individuals and cause them to make different choices about the foods that they eat, medications they use, so on and so forth. There is reproductive technology now to avoid passing on genetic variants that people with PKD may be interested in learning about when family planning. So it's important to know what that specific gene and variant is if someone's going to be thinking about something like that. I wanted to point out too, there's a PKD Foundation chapter coordinator, Dwight Odland, who actually wrote an article about this, the benefits, limitations of genetic testing, and it's available online. It might be an interesting read for some folks. Another reason to consider testing is that it can help with donor selection. So if there's a relative that's being evaluated as a possible donor, we'd want to make sure that they did not inherit that specific spelling error in that specific gene. And then lastly, genetic testing and kind of knowing exactly what gene is involved for you may allow for inclusion in future clinical trials and research. So it's kind of a really big area of study is, can we get even more gene-specific therapies and medications for all sorts of different genetic conditions? So are there downsides to genetic testing? I'm asked this question a lot by people who come in to see me and to talk about testing. I don't know if I'd call them downsides per se, but there's certainly some considerations. First of all, testing isn't just a positive or negative result. So sometimes we find variations we don't have a lot of data on, we don't know how to interpret. Humans have normal differences in their spellings of their genes. That doesn't automatically mean if we find something like that, that it's the cause of PKD. We really need a lot of evidence to know for sure, so it may take some time to get to that final answer. Speaking of time, the test itself can take a few weeks. So typically you'd expect to wait anywhere from 3 to 6 weeks to get those genetic test results. It's really lab dependent, although if there was a very time sensitive situation, a lot of times labs can do stat testing to speed that up. There are, of course, psychological and emotional impacts on people who discover that they either have a condition or are expected to develop a condition. And then with PKD specifically, the current status quo is really to not do genetic testing on children, since at this point in time, as far as I understand, it does not change medical management really until adulthood. That may change if and when there are medications for asymptomatic people to delay that onset and progression. When it comes to insurance, just like anything else in the medical record, genetic testing can be used by life insurance, long-term care insurance, and disability insurance companies. So that's separate from your health insurance, which is protected federally, and they cannot change your premiums or anything like that. But if you're applying for a life insurance policy, for example, they can use the fact that you have PKD, they can use the fact that you've got a positive genetic test result, they can use just about anything that they can find to change what is offered to you, or even whether or not you are offered a policy. And then lastly, a lot of people have questions about cost. There can be a cost with genetic testing. It's really insurance dependent, but there are labs that will do benefit investigations with your insurance prior to proceeding, and typically will offer a cash pay price for a couple $100 if the insurance coverage is not very good. And then this is my last slide before I'll turn it back over to Dr. Dahl, just what to expect in a genetic counseling appointment. And the reason we have appointments for genetic testing with a genetic counselor is that informed consent is really a major component of proceeding with testing like this. It's not just an easy, I'll learn in a couple hours if my this, that, or the other thing is high. This is pretty involved, and with those insurance implications, it's just important to know what you're getting into or not getting into. The genetic counselor is not going to be there to convince you to get testing. We really want to give you the information and the tools that you need to make a fully informed decision that's right for you. But topics that we'd cover would include benefits and limitations, kind of the logistical aspect like the billing and the turnaround time. A family history will often be gathered. So if you know those details about aunts, uncles, cousins, that would be really helpful to hear as well. And then if you're not sure if testing is right for you, the genetic counselor is really there and trained to navigate that decision-making process. Going back to Dr. Dahl and her example, her case study.
Okay, so we are back with this patient. And what I would say when we're discussing genetic testing with our folks with PKD, if there's no family history or if the imaging looks atypical, like it doesn't quite look exactly like PKD, those would be other reasons that we might consider testing in addition to testing for prognostic information. But here we're back to our patient who is at intermediate risk in terms of imaging, sort of the Mayo imaging 1C classification. Next slide, please. And she decides that she wanted to undergo IVF, in vitro fertilization, with pre-implantation genetic testing. And this way, because we know if we know what her gene variant is, then we can select those embryos that don't carry that PKD1 gene variant. And she underwent sequencing, and she has what we call a truncating PKD1 variant. And this is just what that protein variant is. So at this amino acid position, there's no further amino acids added to that protein, and that protein is unstable. And people with truncating variants, we essentially think of them as having no polycystin 1, which is the protein that's made from the gene PKD1, no polycystin 1 in the cells that are expressing that variant. Next slide, please. And so we talked a little bit about the pro-PKD score, and so I wanted to explain what that was a little bit more. So it's a score that's based on 4 variables. The variables are the sex of the patient, male or female, whether they developed hypertension before the age of 35 or a urologic event before the age of 35, and what the mutation type is. And here what you can see is the type of variant that our patient had, that truncating PKD1 mutation where there was no protein made, gives you the highest number of points. There are 2 genes, as Kayla mentioned, that cause most ADPKD, and they're called PKD1 and PKD2. And about 80% of people have PKD1, which is the more severe of the 2 genes with the earlier onset disease. And about 15% have PKD2. And so here the point score, you get a point for being male, a point if you develop hypertension or a urologic event before the age of 35. Those are high risk features in PKD. And then points based on what the mutation type is. So no points for PKD2, which is the milder of the 2 genes that cause this disease. And then if you have a missense or non-truncating PKD variant, that's 2 points. And a truncating PKD1 variant is 4 points. So our patients, she developed hypertension before the age of 35, actually developed hypertension during her pregnancy, and had 4 points for having the truncating PKD1 variant. So she has a total of 6 points from this calculator. Next slide. And you can see that these are how the points are allocated. So the high risk folks are the folks who have 7, 8, or 9 points. And here, the average age of developing end-stage kidney disease is about 49. So these are the highest risk patients. For people who have that intermediate phenotype, the risk of developing end-stage kidney disease is about 57 years old. So she's in this phenotype. And then this is often very helpful if we have the information of determining those people who are then at the low risk phenotype, who may not develop kidney failure at all, or if it occurs, it may be a very late event. So this is just another way along with that Mayo imaging calculator, which is looking at kidney size, of giving people an initial assessment of what to expect when the kidney function is still normal and the kidneys are not very enlarged. Next slide, please. Okay, so these were her 2 results. By the Mayo imaging class, if she stays true to that 1C classification, in 10 years, her kidney function will be around 48%. And in 20 years, she'll be approaching end-stage kidney disease. And by the PKD score, then she has a 50% chance of reaching end-stage kidney disease by the age of 57. So they're giving different assessments, both of them saying that she is likely to develop end-stage kidney disease. Next slide, please. So in this case, we did genetic testing primarily because the patient was interested in pre-implantation genetic testing and in vitro fertilization using that pre-implantation genetic testing. But in cases with typical PKD, it's a discussion with your provider whether or not you would like genetic testing and whether that will add something to the management or add something that may be helpful for your family. For patients with atypical imaging or for patients who have no family history of ADPKD, we think that there's a benefit to doing genetic testing because there are genes that mimic PKD1 and PKD2 in that they look like PKD1 in that there are cysts in the kidneys and maybe some cysts in the liver, but those genes may be milder in terms of the disease that they cause than PKD1 or PKD2. And so if you have one of those other genes, you may have a very different course in terms of clinical progression. Knowing the type of variant you have, knowing how at risk your family is, may help you kind of think about how to counsel the generation coming after you. And in the future, what we think may be true is that there may be therapy that's specific on knowing the type of genotype. So there may be drugs in the future that are specific for people who have missense variants or specific for people who have other kinds of variants. And so we're just starting to think about that and starting to think about how do we start classifying patients if this is going to be the therapy of the future. Next slide, please. Right, and that brings us to the final bit to see if there are any questions, either in the audience there or online.
Rachel, I did something to this. Okay, there's one question in the audience. Go ahead, Rachel. I can't see it because now okay.
There's one question in the chat. Say, I had PKD specific and broad spectrum genetics done and all came back negative. No family history neither. Why didn't something show up? I'm stage 5 and going on PD now.
So I will answer that, and then Kayla may want to answer that as well.
Yeah.
So the testing that we have to date isn't 100% sensitive. So even with the best testing, it's possible that we're missing the variant that's causing the PKD. And so that's really important. And that's a very good point about pointing out some of the limitations of our current testing. Sometimes we start with one test, and if we don't see it with that genetic test, we can go further and do a more detailed kind of testing. So sometimes we'll start with what's called a targeted gene panel, and then if we don't see something there, we can move to whole exome sequencing or whole genome sequencing. If the testing is negative, this is the kind of thing that we're very interested in from a research perspective. So at Mayo, we have a large study going on, and at Yale and at Hopkins, there's also interest at Maryland in looking at these patients to see if we can sort out like what's going on exactly. It may be that we've missed the mutation, or it's in a part of the gene that we don't typically sequence, or it's in a different gene that looks like PKD. So this is a really important point, and you know, it's a very interesting area for us to think about. So that's a good point. Kayla, did you want to add?
Yeah, no, you covered all the pieces that I would have. Definitely there's limitations to our understanding in technology right now, but it's very interesting for us, especially on the research side, to keep looking for those causes if we don't find one on our first or second pass.
Do we have any in-person questions? Otherwise, we have several in the chat that I will look at. Okay, we'll go with the chat.
Okay. I'll go in order. I was recently diagnosed with cysts on one kidney and my liver. Does the PKD always develop in both kidneys?
So I will answer that. Sometimes what we see is something called mosaicism. So particularly if there's no family history, what happens is there's an early event in development, and there's a variant that forms that can cause disease in some of the cells that then develop from that original embryonic cell, but not in all of them. So when we see things like this, like cysts in one kidney and then the liver, so it looks like there's only partial expression of PKD, we're worried about this question of mosaicism. And that again is sort of one of the cutting edges of where we are with genetic testing now, because sometimes it's harder to detect mosaicism with standard testing.
Okay, one more. We have a lot of questions. We may not get to all of them, but here's another one. If the father of the IVF couple has a PKD1 truncating mutation and the grandmother has the same gene, what kind of genetic testing is needed? So in other words, proband and grandmother, they all have a PKD1 truncating mutation. What further testing is needed?
To do the
Yeah, for IVF, for an IVF couple.
Okay. So for IVF, so in this family, we know the disease causing variant. We know the variant that's causing PKD. And then typically they, when they do IVF, they look at SNPs to see like what are the SNPs that sort of correlate with that variant in that family. So they may ask for DNA from various family members who have the PKD, so they can make sure that they have the right markers, the right satellite markers around that DNA to be able to definitively test each embryo and make sure that that embryo is not carrying the PKD variant.
Okay. There are some questions in the chat. If Anira and Kale, I know I've seen you guys are answering them online, which is great, but we're going to move on in the interest of time, if that's okay.
That sounds
Thank
great.
you. Thank you very much. Those were two really great talks. Thank you.
Thanks.
Thank you.
Okay. So, okay. We were scheduled for a 5-minute break. Can we do that? Okay, we're moving on. All right. So our next topic is actually on tolvaptan and GnRQ. We have two speakers again. Our first speaker is Dr. Val Sabotaru, who is a nephrologist here, my colleague at the University of Maryland. He's been working in PKD both clinically and in research for the past 15 years. And our second speaker is Erin Dolan, who's a registered nurse in the Division of Nephrology and Hypertension at Mayo Clinic in Rochester. She's working with their PKD Center of Excellence. She has tons of experience in medical nephrology, not only in PKD, but as a post-transplant coordinator, et cetera. So I guess I'm going to turn it over to Val to begin.
A little bit of terminology. So most of you know tolvaptan by the name of GnRQ. I will refer to it during this presentation as tolvaptan. Tolvaptan or GnRQ is the first and the only FDA-approved drug for ADPKD. So how do we measure renal function? We use GFR or estimated GFR to measure renal function. Normal GFR it's around 100, and when GFR is less than 5 to 10, then it's time to start dialysis. As already has been mentioned that ADPKD it's a hereditary disorder. It presents with bilateral renal cysts. It leads to progressive decline in renal function, and about half of the patients will end up on dialysis by the 6th decade of life. There are also extrarenal manifestations of ADPKD, such as liver cyst, pancreatic cyst, brain aneurysms, and cardiac malformations. So why do we use tolvaptan? So in preclinical studies, it has been shown that when they used a drug similar to tolvaptan, they used PKD rats that develop cysts, and then when they used a drug similar to tolvaptan, it slowed significantly slow cyst growth, as you can see in the left upper panel. And then they used the same drug in a few other animal models, and they got the same results. When they used this drug similar to tolvaptan, it slows cyst growth. And tolvaptan works by blocking vasopressin receptors, so this way it decreases vasopressin action.
Your slides aren't being shared.
Again, as you can see in left upper panel, when they used a drug similar to tolvaptan, it slows cyst growth in a PKD rat model, and then they used the same drug in few other models, and it significantly decreased cyst growth in these animal models. In the right upper panel, it's another elegant experiment that when they show that when they crossed a PKD rat that has a mutation, a PKD gene, with another rat that has a deletion of vasopressin, this resulted in a decrease of cyst growth, or these rats did not develop cysts. And then when they reintroduced vasopressin, this animal model started redeveloped cysts, again showing that vasopressin has an important role in cyst formation. And tolvaptan blocks vasopressin receptor. Okay. There were two clinical studies that tested tolvaptan in humans. First study was published in 2012, TEMPO study. And in this study, they enrolled patients between the age of 18 and 50 that had early stages ADPKD with eGFR more than 60. And second study was published in 2017, a REPRISE study. And in REPRISE, they enrolled patients between the age of 18 and 55 with more advanced ADPKD with eGFR between 25 and 65. So TEMPO study shows that tolvaptan increase in total kidney volume by half compared to placebo or control group. So in the left side, you can see a graph that shows increase in total kidney volume. In blue line shows increase in total kidney volume in tolvaptan group, and in red line or red dots showed increase in total kidney volume in placebo group. As you can see, tolvaptan slows increase in total kidney volume, but it doesn't stop cyst growth, it doesn't stop cyst formation. And right upper corner, it shows that tolvaptan decreased total kidney, in tolvaptan group, total kidney volume increase was about 2.8% per year. And in placebo group, total kidney volume was about 5.5% per year. And 2.8%, as I mentioned, is about half of 5.5. Tolvaptan also preserves renal function. And TEMPO study shows that tolvaptan decline in GFR by about 34% per year over a 3-year period, and Reprise decrease the decline in GFR by about 35% over a 1-year period. And this is shown in a graph on the left side. Blue line shows decrease in GFR in tolvaptan group, and red line or red dots shows a decline in GFR in placebo or control group. And again, as you can see, tolvaptan slows the decline in GFR, but it doesn't stop disease progression. It doesn't stop decline in GFR. Reprise study had a post hoc analysis. This means that they follow patients for another year, and they look at patients with more advanced disease. And so specifically, they look at patients with GFR between 15 and 24, because initially they enrolled patients only with GFR above 25. And when they looked at decline in GFR, you can see tolvaptan group as shown as a blue line in the graph, and placebo as an orange line. They again show that tolvaptan decreased the decline in GFR by about 35% over a 1-year period. So Reprise trial divided patients in 2 groups, younger than 55 years old and older than 55 years old. Most patients were younger than 55 years old. There were over 500 patients in tolvaptan group and over 500 patients in placebo group, younger than 55, and less than 100 patients in tolvaptan group and less than 100 patients in placebo group. They were older than 55. And they show that in patients younger than 55, tolvaptan had a significant effect in decreasing decline in GFR, but in patients that were older than 55, tolvaptan did not have any significant effect on decline in the GFR. And there may be few explanations for that. One reason may be because this patient have advanced disease and they have too much fibrosis or too much scarring in the kidneys. And for this reason, tolvaptan had no effect. Another explanation may be because this group was too small and could not reach statistical significance. There was no difference when they looked at females and males. So in both groups, tolvaptan had a significant effect on slowing decline in GFR. So there are some adverse reactions with tolvaptan, such as increased urination, thirst, elevation of liver function enzymes in about 5% of the patients, increase in uric acid level, and this is important for someone who has gout. It can interact with other prescribing drugs. So who should be treated with tolvaptan? First, it has to be confirmed that patient has ADPKD based on imaging and family history. And if there is no clear family history, then genetic testing is recommended. And then it has to be determined whether patients have a rapidly progressive disease or slowly progressive disease. So tolvaptan, it's indicated only for those with rapidly progressive disease. And it's approved for patients between the age of 18 and 55, and GFR has to be 25 or higher. So who has a rapidly progressive disease? As Dr. Dahl already showed this slide. So patients are divided in 5 classes, A, B, C, D, and E, and those who are class C and have a total increase in total kidney volume more than 3% per year are classified as rapidly progressive or class C and higher. Those who have class B or A have less than 3% increase in total kidney volume, and for those patients, tolvaptan is not recommended. So class B, it's intermediate, and they can switch, if they can go from progress to class C, rapidly progressive disease, and in this case, tolvaptan would be recommended. So for those patients, it's recommended to have an MRI to assess kidney volume every 2 to 3 years. But as long as they remain in class B, tolvaptan is not recommended. There is also an association between kidney size and decline in GFR. So if someone has a So if someone is class 1E, you can see that a dark gray line, and if let's say starting GFR is around 75, then over a 20 years period, GFR will be above 50, and it shows it's a slow decline in GFR, and for this class, tolvaptan would not be indicated. Versus if someone has a class 1C, a rapidly progressive disease, it's a yellow line. It's the same, if starting GFR is around 75, but over 20 years, GFR will be close to 0, and these patients will need, this patient tolvaptan would be indicated. So this slide shows that increase in total kidney volume and decline in GFR, it's not linear. On the left upper side of the slide, you can see a graph where it shows the increase in total kidney volume. So initial total kidney volume, it's low, but as disease is progressing, then there is a more rapid increase in total kidney volume. And if you look in the right upper corner, you can see on this slide that the same thing happens with GFR. Initial decline in GFR is low, but over time, decline in GFR is more rapid, it accelerates. Also shown in this table in the right lower corner. So for example, if someone is class 1C, rapidly progressive, and it's less than 30 years old, GFR decline, it's about 0.5 ml per year. But if someone is in the same class, but 50 years older, then decline in GFR, it's about 4.7 ml per year. So as disease progresses, there is also decline in GFR, it accelerates. So what are potential benefits of tolvaptan treatment? So on the left side, if it's shown that if someone, based on tempo trial, if someone has a starting GFR of 90, then they would reach dialysis in about 20 years, and it's shown in a red line. Now, if tolvaptan is started, then it would delay initiation of dialysis by about 7 years. It's shown in a blue line. On the right side, based on the REPRISE trial, if someone has a GFR of 45, then they would reach dialysis in about 8 years. And if tolvaptan is started, then this would delay initiation of dialysis by about 4.5 years. So how is tolvaptan administered? Usually it's taken twice a day, first dose in the morning and second about 8 hours later. With tolvaptan, there will be increased urination and due to thirst, patient will ingest a large volume of water between 4 and 6 liters a day. As mentioned earlier today, it is recommended to avoid soft drinks because it can lead to weight gain. Tolvaptan should be held if someone has nausea, vomiting, or diarrhea, or it has poor oral intake for any reason, because this can lead to dehydration. Also, if someone travels and doesn't have access to a bathroom, then it's recommended to hold tolvaptan. So as I mentioned, about 5% of the patients have an elevation in liver function test, and for this reason, liver function tests are recommended very closely. So it is recommended to have a baseline liver function test, and then once tolvaptan is started, it's recommended to have a liver function test at 2 weeks apart twice, and then once a month for 18 months, and then every 3 months. If there is an increase in liver function test, then tolvaptan dose needs to be adjusted or discontinued. Depends on how much change in liver function test. In summary, tolvaptan is not a cure. Tolvaptan slows renal cyst growth and also slows the decline in GFR in patients with ADPKD. It's indicated only for rapidly progressive ADPKD, and it needs close monitoring.
Okay.
Hi, everyone. So we're going to kind of recap everything that was just said. If you can't hear me, let me know. Let me get this
I
in
can
the
hear you.
slideshow. Okay, thank you. All right. So as he just said, that GnRQ is a medication that's prescribed to treat rapidly progressive ADPKD, but it is not a cure for it. We're just slowing down the progress, delaying that need for dialysis and transplant in the future. The things to consider when you're looking at GnRQ, so the benefits of it is it slows down that kidney growth, which in turn will slow down that eGFR decline, ultimately delaying that need for dialysis and transplant. There have been reductions in symptoms with some people taking GnRQ, particularly if your cysts are creating a lot of pain. We have had people tell us that it has significantly improved their quality of life going on this medication, so that's always one thing to consider. Some people have also noticed a decrease in blood pressure while on this medication, so that needs to be monitored while you're taking it as well. The risks of it are the side effects that everybody's heard about: increased urination during the daytime and the nighttime, increase in thirst. So this medicine is making you drink, so you're just going to have to carry water with you all the time. Some people report being more tired. I will say this occurs more often in the first couple months on the medication while your body's still getting used to it. So if you give it that full 2 months, usually you'll start to adapt to it a little bit more. There is that risk of liver injury with this medication, which is why there is all this monitoring with it. And there are interactions with other medications. So if you're started on anything new, we definitely want you to discuss it with your pharmacist to make sure that there's anything that might need to be stopped or held, or an alternative treatment recommended. Particularly, some antibiotics interact with the medication, including antifungal medication. Things to consider, he already kind of went over this as well, that we want you to hold that GnRQ and feel empowered to do that. If you have an acute illness with vomiting or diarrhea, you're unable to keep any fluids in, we want you to hold that until you're eating and drinking normally again. If you're undergoing any surgical procedure, just go ahead and stop this medication a day or two prior and then resume it when you're eating and drinking normally again. I have had some people hold the medication for like a knee surgery and then they don't take it again until they're able to mobilize a little bit better. If you're hospitalized for any reason, we're okay with you stopping that medication. And then traveling, if you're unable to obtain a good water source, may not want to take it. Otherwise, a lot of people, if you travel every once in a while, you might want to hold it if you're traveling on a plane just because bathroom availability is not always there. And then if you become pregnant, we do recommend discontinue taking the medicine. So what is REMS and why is it needed? So REMS stands for Risk Evaluation and Mitigation Strategies. It is an FDA mandated monitoring program. This is to help ensure that the benefits of GenRQ outweigh the risks. They are the one that dictate the required lab monitoring, and that's to ultimately reduce the risk of liver problems through close monitoring. Only prescribers who are enrolled in the REMS program are allowed to prescribe it. Currently, there's only 3 commercial pharmacies that you can receive this medication from. Panther, Optum, and Alliance. They are all mail order pharmacies. If your insurance is not covering it, there is the Otsuka Patient Assistance Foundation that we can look into as well. You do only get 1 month supply at a time from the pharmacy. The mandatory lab testing, he already went over, but it's weekly times 2, monthly for 18 months, and then every 3 months while you're on treatment. If at any point you're not getting your labs done at the recommended frequency, we will put a hold on the medication until those labs are started back up again. So what symptoms would you need to watch for if there was a concern for liver injury? Right upper stomach pain or tenderness. This would be different if you have PLD also, or you're used to having pain there. It's something different. If in addition to that you have vomiting, you're having fevers, you're getting itching all over your skin, yellowing of the skins or the whites of the eyes, that's also called jaundice. And then if your urine is dark in color, we want you to stop it. We want you to let your care team know right away. Dark colored urine, it could also mean that you have a cyst that ruptured, so it doesn't necessarily mean that it's a problem with the liver, but your care team needs to know about it. That was just a quick run through because I know we are running out of time, so if there's any questions.
Okay, sorry, guys. Thank you, Erin. Thank you, Val, for those talks, and we're opening it up for a few questions.
Okay, so we have one from the chat. If I drink 4 liters of water every day, are there additional benefits to taking tolvaptan 2, or is the urine dilution the most important factor to help the kidneys?
I think Dr. Chabib showed a study that only ingesting water, it's not enough. It did not show any benefit in slowing down cyst growth. So yeah, answer, it's not enough. You still need tolvaptan.
We have a question from our live audience.
Yeah, how common are liver problems?
As I mentioned, about 5% of the patients have elevation in liver function tests.
If you are a male and planning to have a baby in the future, can you take tolvaptan?
I'm not sure if there is any data. I'm not sure if there is any data. I think.
I think that and I think
In our practice in Rochester, we don't have anybody stop it if they're a male and family planning at this time.
we're going to move on. We're going to move on to our last session. Okay, our last topic is on PKD research. We have 2 speakers, Chuck Madsen, who has worked with the Mayo Clinic PKD research group for a long time. He has worked on all of the major PKD clinical trials and with Vicente Torres. And then Steve Seliger, who is Associate Professor of Medicine, my colleague here at the University of Maryland, who leads our clinical trial effort here.
So yes, I have been with the Mayo Clinic PKD Research Center for quite some time. My goal here today is to briefly explain what clinical research is, how it works, reasons patients choose to involve themselves. At the end, I will also briefly introduce our clinical research team at Mayo, Rochester, and the projects we're currently involved in, which does not include all of our lab and basic research personnel, as the whole team is rather large, illustrated a little bit by this picture right here. So, what is clinical research? And at its most rudimentary, clinical research is the study of health and illness. There are two different types of research involving people. The first would be observational studies, where we are endeavoring to learn about the disease or condition that we are interested in studying. Sometimes comparing affected individuals to unaffected controls. In PKD, these studies often include imaging, lab sample collection, and quality of life evaluations. And then clinical trials are research studies that test new drugs, treatments, or medical approaches in people, the goal being to determine safety and effectiveness. Clinical trials go through different phases. The first phase, phase 1, tests the safety in a small group of people, 20 to 80 perhaps. If that shows promise, it moves on to a phase 2, which evaluates effectiveness in a slightly larger group, maybe 100 to 300 people. And then again, if that's showing promise, we move into what's known as a phase 3, which are large groups, 1,000 to 3,000 patients quite typically. It helps confirm effectiveness. It monitors effects long term. For anybody out there that was involved in any of the tolvaptan trials, you know how that we kind of stepped through those different phases with that. It went on for many years. A clinical trial follows a detailed protocol, and that guides all of the personnel involved, and it helps ensure consistency across sites. Especially medication trials are usually multi-site. They're sponsored by the different pharmaceutical companies, and they are drawing in patients from sites across the country or across the globe, and the protocol helps ensure that we're all doing things the same way. And so both the participants, the patients, and the study staff need to follow this plan. Anytime we have a deviation from it, it needs to be recorded, as it may impact the analysis as we move forward. Protocols are reviewed by regulatory authorities. In this country, that's the FDA. And then there are local institutional review boards, and those help to ensure that the trial is designed to protect participant safety and produce reliable data. And as informed consent is another essential process in the research process, and it provides participants important information about the trial, the procedures, the risks, the benefits, and hopefully helps them make a wise decision about whether to take part. And then this is just a table that briefly describes the difference between clinical research and medical treatment. And again, the big difference is research is focused on studying new approaches to determine safety and effectiveness. with the goal of advancing our knowledge and benefiting future patients. Whereas medical treatment is aimed at the individual, and we're looking to improve your health using accepted and proven methods as the treatment. So why would you want to participate in a research trial? And every participant we has their own motivations, their own reasons for wanting to take part. Some of them are just wanting to help advance medical knowledge and helping others. These volunteers are playing a vital role in moving medicine forward. Another reason is you get access to new cutting-edge treatments. Experimental therapies that are not yet available to the general population may potentially improve their own health, especially if they have not been responding to the proven treatments. Another benefit is, if you will, is you receive close oversight and care from a dedicated team, which can lead to better management of their condition. Quite often in clinical trials, you are not paying for any of that treatment. So it's an opportunity to see a PKD specialist on a regular basis. And this goes back a little bit to my discussion of the informed consent. But before joining a clinical trial, it's very important that you understand what is involved, the risks, the potential benefits. Our primary clinical researchers at Mayo Clinic, Dr. Dahl, who you've heard from, Dr. Hanna, who is well, not too recent. He's been with us for a few years now, but he is our first pediatric nephrologist interested in PKD. So we're very excited to have him. I've been learning a lot about pediatrics and working with children as part of this. Dr. Harris, who is our geneticist. In the genetic talk, he's the one who does a lot of the research at Mayo into the different genes and how they impact PKD and progression. Dr. Hogan, and she has a specific interest in polycystic liver disease. Dr. Razabal, we were talking about the Mayo classification. She is the primary force behind that being developed. And then Dr. Torres, who he's been doing this for a long, long time. Many of you have probably heard his name at one point or another. Oh, studies that we are currently doing at least at Mayo Clinic. And the first one up is with Dr. Dahl, and the coordinator working with her on that is Katie Heiberger, and it's an imaging studies. There's Dr. Hanna as our pediatric specialist, and he's got a couple of studies that he's recruiting for looking at tolvaptan in ARPKD patients. And he is also doing those observational studies that I mentioned, looking at urine and MRIs versus 3D ultrasounds. Dr. Hogan has a medication study that we're looking to recruit for from a company called Regulus. And Dr. Harris, and he's, again, for anybody who's interested in genetic testing, and as in the previous discussion, this is the sort of the research side. often takes longer, but this is how we identify some of those different variants that were not known before, is through the collection of DNA. And then Dr. Arazabal has some other imaging and studies that she is working on. And then I wanted to throw out this for Dr. Shabib down in Jacksonville, because he does have a study looking at using a medication called probenecid to help alleviate some of the diuretic effects, hopefully, for patients on tolvaptan. And then this one is not enrolling, but Dr. Hogan does have a study going in PLD using octreotide, a new delivery system. So yeah, that's
Okay, thank you, Chuck. We're going to move on to our last talk by Dr. Seliger.
Thank you, and thank you so much, Chuck, for that very comprehensive review. So I'm Dr. Seliger from the University of Maryland, and I've been working with Dr. Watnick for now over 13 years. And the reason I'm here and the reason I'm in this field is actually entirely because of her, so thank her for that. So just to expand a little bit on what Chuck very nicely distinguished the different types of clinical research, one way to think of the observational type of study is it's a natural history, right? There's no experimental intervention. But it doesn't mean that this research is unimportant. It's extraordinarily important. So in the first section, Dr. Shabib showed the data linking obesity or high body mass index with more rapid progression of ADPKD. That's observational natural history research, right? So that research can be extremely impactful. Studies that all the group at the Mayo Clinic that have tried to carefully define how common intracranial aneurysms are, how frequently they develop, and how quickly they grow. That was done for decades of observational research. So that research can be extremely impactful, even if it's not specifically testing a new treatment. Controlled trials, of course, do test or often do test new treatments. And to add to what Chuck very nicely said, some key components of that are the notion of randomization. That is, you're volunteering to be randomly assigned to different treatments. Usually that's an active treatment and a controlled treatment. And why are you randomly assigned? Well, the randomization ensures that the two groups are exactly the same. The only difference between them is that one's getting active drug and one is getting a different or controlled treatment. So that randomization is very key. The control treatment is often, if it's a treatment of a new medication, it's a placebo. I'm sure you've all heard the term, of course. Placebo is a pill for medication that looks, tastes, smells exactly like the active drug, but there's no active ingredient. Why do we give that? Well, because we know that when people receive a medication, or whether or not it's active or not, they often feel better, right? They often take better care of themselves. So this is a way to isolate the effect of the active ingredient. Chuck had reviewed this too, but just to add that the phase 3 trials, which are the types of trials that eventually lead to approval of the drug, are preceded by these phase 1 and 2 earlier stage trials. These are also very important. We can't get to phase 3 until we've gone through these earlier phases where we're testing different doses, safety of the drugs over relatively shorter term, and even initially in people who don't have PKD, so that healthy adults, healthy individuals can volunteer for those. And also to note that, as you saw with tolvaptan, after the drug was approved, that was not the end of the studying of the drug. There was a phase 4 study, a so-called open label study, where we continue to gather information about the safety of this drug even after it was approved for sale and market. The informed consent process, as Chuck highlighted, is really the crucial crux of participation, or the initiation of participation in studies. So we refer to it as a process. Not often we talk about the document that you sign, but the document is really to guide the process. And the process is a series of conversations and communications between the research staff, not just the physician, but the whole team, and a potential participant. As Chuck alluded to, we provide key information, but we want to confirm that you understand the information comprehensively and that any decision that you provide to participate is voluntary. And that's shown in this very nice diagram here conceptually, that we have 4 components or 4 factors that lead to what we call meaningful informed consent. And of course, the voluntariness is really ultimately the key. It's entirely your decision, entirely your decision. So just to note that, of course, there are still benefits to participate as Chuck described. I do want to highlight, though, that one can also receive a direct benefit, right? So the direct benefit could be if you have a new treatment that's being tested, and if the new treatment actually succeeds, is effective, and if you are randomly assigned to that treatment, then you will absolutely receive direct benefit. Even if the treatment ends up being ineffective, or even if you receive placebo, you can still gain direct benefit. And that might be from more careful disease monitoring or careful measurements. And we've referred throughout this morning to total kidney volume as a major marker for risk stratification, risk prediction. In fact, that in clinical care, that may actually be hard to achieve. And so often, as part of a research study, almost all of them, total kidney volume will be quantified using a highly validated way, and that can be of benefit to you regardless of what other treatment is involved. Of course, what motivates so many people to participate is the potential for benefit to the larger population of people in our country and in the whole world who have polycystic kidney disease. But even more narrowly, as Chuck very nicely said, to the generations within your family that, or maybe your siblings, your children, but then generations not even yet to come. And that's the only way that we have got here. The way that we've gone from, in such a really short time, identifying the gene that caused this disease to having the first treatment FDA approved. It only happened because thousands of people agreed to participate and donate their time and everything else to participate in research from the earliest stage to the later stages. So I'm just going to highlight 2 of several of the studies that are in our portfolio that are occurring at the University of Maryland. One is a long-standing and ongoing observational study, or sometimes called a cohort study. Just to clarify that Dr. Watnick and our research is focused on adults with ADPKD. We are adult nephrologists, not pediatric nephrologists, so that this would be true for this study as well. Because it's observational, again, there's no treatment being tested. There's no randomization. We are very fortunate to be part of a multi-center consortium that is funded by the National Institutes of Health, which is designed to provide resources to researchers studying ADPKD around the world. And so we, along with other sites in the country, and have been collecting clinical information and blood and urine samples linked to that information on patients. This is all stored anonymously without your name or anything. And then those samples and that information is shared with investigators who are looking for, say, new biomarkers or new pathways, molecular pathways to understand disease progression. What involves is an in-person visit for about half a day, morning, say, to our clinical research center here on this campus once, and then again at 3 years. We ask you to come back, and obviously some people, they move away and they're unable to, but we ask you to try to do that. We do quantify the total kidney volume. That's part of this protocol, so you'd get that. We have lots of questionnaires about how you're feeling, thinking, how much pain, and so forth. Of course, kidney function, liver function are measured. And then we check in by telephone once a year, find out if there have been new complications that have developed. We have a clinical trial that's ongoing as well. This is funded by the National Institutes of Health. This is among our clinical trials. This is a trial of a drug called empagliflozin. I'll just spend a minute telling you a little bit about it. Empagliflozin is sold under the brand name Jardiance, and so you may have seen this as being advertised on television now. It was initially a drug that was developed for the treatment of type 2 diabetes, people who have high blood sugar. And it works by blocking the reabsorption of sugar in the kidney. So normally we filter lots of sugar through the glomeruli, the filters of our kidneys, but then we reabsorb that sugar after we filter it. This blocks that process, and through a complicated series of mechanisms, that can lead to slowing of progression of chronic kidney disease. And in fact, it is approved for that purpose in people with and without diabetes, but not approved and recommended not to be used clinically in people with ADPKD. Why is that? Well, because the companies that developed this drug, and there are multiple drugs like it, they excluded patients with ADPKD from all of the clinical trials. So in fact, this study is to test this drug in ADPKD for the first time. And this is from one of the landmark trials of empagliflozin in over almost 7,000 patients with chronic kidney disease, but zero with PKD. And it showed that the primary outcome here, progression of chronic kidney disease to kidney failure or death from cardiovascular disease, as you can see on that yellow line there on the right side, was substantially lower than the group that got matched placebo. So it was a randomized placebo-controlled trial. Whether this applies to PKD, that's what we're trying to initially get a sense of and to find if people can take this drug safely and tolerate it over a period. So we have people who come in for a screening and baseline visit. They're then randomized to have an equal chance of empagliflozin or matching placebo. They come back at 3 months and 12 months to see us in the research center. They get MRIs at each time and other questionnaires. And then we also check on their labs and their kidney function, liver function for safety at different times. And that's done remotely via Quest, and then we call them to find out. So there's 3 visits involved over a 12-month period. And we do have reimbursement available for participation. And this is individuals that I certainly encourage you to contact both myself, Dr. Watnick, who's here, Rachel, and then Charlotte Diggs, who was unfortunately unable to be here, but has been our research nurse for over a decade and has worked very closely with patients. And that will be it. Thank you so much.
Thank you, Steve and Chuck. Do we have time for questions? Okay, questions? Okay, we're going to take one from here first. Go ahead, and then we can.
Yes, the question was.
Wait, just repeat the question.
Yeah, the question, which was excellent, is if you're already taking tolvaptan, can you participate in the Jardins trial? And I should have clarified that. At this moment, we're not studying in people who are already on tolvaptan. We want to begin by establishing its safety in people who aren't. And Jardins does cause an increase urination as well. So we were concerned about combining them. Ultimately, though, that has to be tested. So an excellent question. Thank you.
Okay, I don't see any other questions coming in the chat. No more in person. Okay, so we are going to take a few-minute break, and we are going to be getting into our breakout groups.
And I just want to thank everybody who participated, both in the audience and the speakers. It's been great. Thank you so much.